the spine. So we've got some excellent speakers lined up. We're going to give you an overview of some FRCS hot topics to chat about. Before I get started, some housekeeping. So as per usual, if you've got some questions, can you please ask them in the Q&A box? And we'll try and answer as many as we can at the end of each talk, and if there's time at the end of the session. If you could please complete your feedback that you'll get at the end of the session and email to you if you miss the link at the end. It really helps us just to keep these things going and to build upon your suggestions. Quick plug for our virtual congress we've got later on this year. So it's running on the 5th to the 7th of July. We're doing a hybrid event with some pre-congress courses running on the 5th with an FRCS Viva course and an ST3 bootcamp, which are excellent value for money. And then the actual Congress on the 6th and 7th of July will be virtual. So if you're interested, follow the link there via the QR code and sign up. And if you're interested in joining the committee, you need to sign up for our AGM. So these are the flyers for our Viva course and the ST3 bootcamp. The Viva course has been run by none other than Beneskovich himself with postgraduate orthopedics, and the ST3 bootcamp is being run by the BOA. And we've also got an in-person medical student day running on the Wednesday, with some excellent consultant-led teaching for our future orthopaedic trainees. So we'll get started. So up first, we've got Mr. Lee Breakwell. Lee is a consultant spinal surgeon at the Sheffield Children's Teaching Hospital, and he is also the spinal advisor to the BOA and the treasurer of the British Scoliosis Society. Once upon a time was president of BOTA, and he's going to talk to you about the intervertebral disc.
Thank you, George. Can you see the slides?
Yes, all good.
Great. So thanks for the introduction and for the invite, albeit it was short notice, and I know who to speak to about that. It's not your fault. So this is a talk a little bit about the sort of basic sciences regarding the intervertebral disc. So for something that is predominantly based around dehydration leading to degeneration, I'll try not to make it too dry. So the disc is a very important structure in the spine. We tend to think of the spine in terms of a functional spinal unit comprising two vertebral bodies with the intervertebral disc lying between, two facet joint pairs, and then all the ligaments and the muscles and nerves, etc. When you talk about any joint, you talk about stability in terms of active, passive, and neurological involvement, and that's no different in the spine. And so the disc is an important part of the passive stability of the spine itself. A lot of people refer to the disc as a shock absorber. Now, in biomechanical terms, that's a bit simplistic, but it is fundamentally acceptable as a model. But it's also a joint, so it gives us our movement as well as taking the strain of movement and load bearing. It's got two main structures, the outer annulus fibrosus and the inner nucleus pulposus, and we'll keep coming back to the various bits of that. And of course, embryologically, and favorite question in the exam is about the embryology, it's a notochordal remnant. Now, this is the bit that's quite hard to get your head around, but it's about 5 and 6 weeks of gestation, you get the trilaminar disc forming the various tubes, and you've got the neural crest tissue, which comes from the ectoderm. And interestingly, the notochord stimulates the ectoderm to form the neural crest tissue, which goes on to form the dorsal root ganglion, the meninges, and all the other sort of neural ganglion. The notochord itself, having induced the ectoderm, eventually becomes the disc itself as the neural tube folds and invaginates. So in terms of the disc structure, the annulus is predominantly made of type 1 collagen. It's lamellated. It's in an alternating oblique orientation. So in the diagram, you can see as you peel back the layers of the onion skin, you can see that the orientation of the fibers is at about 30 degrees to the previous one, enabling it to maintain stretch resistance in all different directions. The nucleus is predominantly type 2 collagen. It's highly hydrated, relatively gelatinous, and as a result turgescent to load bearing once it's hydrated. And then you've got the end plate, which sandwiches the bone and the disc, and that's hyaline cartilage, and that's really important for the nutrient flow and oxygen flow into the disc, as it has no vascular supply beyond early childhood. So in terms of the cellular matrix, it's a macromolecule, and the cells generate this macromolecule in the form of proteoglycans. And it's important to remember that the cells are few and far between, They can't replicate, if at all, maybe slightly in some circumstances, and they are vacuolated notochord cells. And one of the changes with age is the change in the cell nature. The proteoglycans are a combination of a hyaluronic acid chain with aggrecan monomers and a glycosaminoglycan attachments. And the two words to remember are the chondroitin sulfate and the keratan. So chondroitin is one that you'll remember from arthroplasty, the chondroitin molecule, and the keratan. Those two molecules and the proportion of those two is very important for disc and health, disc and biomechanics and health. In terms of nutrition, I've already alluded to this. The end plate is fundamental, and effectively it's via osmosis and active transport across the end plate. There's innervation in the outer zone only. So the annulus certainly has some innervation, and the end plate similarly, and it is highly reliant on the healthy bone. So things like TB, where it damages the bone just inside the end plate, can kill the disc. So pyogenic and TB discitis is often fatal for the disc itself. In terms of disc function, the glycosaminoglycans are hydrophilic, and as a result, they have a high osmotic and hence swelling pressure. And what you can see is that the nucleus is approximately 77% water, and that drops down as you become into the annulus and then the cartilaginous end plate. And the high hydrophilic nature creates the swelling pressures. You'll be familiar with hoop stresses from taper slip hip replacements. And this is an important biomechanical understanding that as the nucleus is loaded, it expands outwards and the annulus holds it inwards, creating hoop stresses within the annulus, which enable the disc to function under load in different directions. And again, the lamellated fibers enable that hoop stress to be evened out in all directions. So this is an old study from Nackhamson. So Alf Nackhamson is a famous name in spinal surgery from the 90s. And what you can see is he took some medical students and skewered them with electrodes in their disc. You'd probably not get ethics for this anymore, but thankfully people did things like this in the past. And what you can see is the baseline is standing in normal straight posture. And when you lean forward carrying a weight, or interestingly sit, the load in your disc goes higher. So this is what is the common scourge of modern mankind. Good for the 3 consultants on the call because it keeps us in a job. But sitting for hours on end, as we all do as a population, increases the load through your disc and probably increases degeneration in the spine over time. And so 80% of the forces in your spinal column go through the disc in normal, healthy spines. In terms of age-related change, and this is really important to understand, that the disc ages normally. My hair's gone grey, it makes me look distinguished allegedly, but it's a normal part of the aging process. So the proteoglycans change, and you get change in terms of the matrix metalloproteinases and things like TGF-beta alternation, and you start to get breakdown of the disc, fibrillation, like in any form of cartilage, and then you start to get abnormal collagen synthesis, and you get this runaway train. And this is a fairly complicated, not easy to understand graph, but fundamentally what it shows is there's a shift in hydration related to age and effectively the reduction in the pressure that you can generate within the disc. So the discs become baggy and sloppy and less capable of withstanding load. You get cracking and fissuring, delamination, cavitation, buckling, and radial bulging, all of the things that lead to pathology. One of the things you might want to talk about is one of the standard gradings for MRI findings is the Furman grade, too many R's and too many N's. And it's 1 to 5. And what you can see is the sort of fairly typical appearance of a normal healthy disc with a clear demarcation between the annulus and the nucleus, and then a gradual dehydration where the darkening on MRI shows the reduction in water. You start to see grey fissuring. Then it becomes darker as the water content drops, and then the height disappears, and then you end up with end stage disc failure. And why that's important is most adult spinal pathology of the degenerative form comes from disc degeneration. So you start off with disc degeneration and breakdown of the nuclear proteins, fissuring, etc. And that can lead down the left-hand side to disc protrusion with radicular pathology, or the shift of the 80-20 split of load bearing onto the facets, leading to facet degeneration, I'm not quite sure what facet syndrome is, but it's one of those things that people talk about. And then you also get facet hypertrophy and buckling, which leads to spinal stenosis. And this is the bulk of what the three of us spend our life treating. So in terms of understanding this biology and chemistry going forward, we've used a lot of animal models. It helps to enable research. And so this is a normal porcine model of a disc in a sort of 6 or 8 week old pig. And you can see the end plate, you can see the cartilage, and you can see the nice, healthy, juicy nucleus. If you needle puncture that disc, and lots of people used to do this for back pain assessment, doing invasive discography, we know that if you put a needle into a normal healthy disc, it rapidly causes disc degeneration. So this is a model simply where you put a needle in, stab the nucleus, and 4 or 5 weeks later in this pig, the disc has collapsed and fallen apart. And clearly a rapid version of normal degeneration. If you take a scan of 100 asymptomatic normal people and plot at their age by the number of disc degeneration, degenerative discs that you see, what you can see is by the time you're 70, 100% of your discs are degenerate. And that's pretty much across the board. It's a normal aging process that doesn't have to be painful, but because of the way you get reinnervation of the annulus, you get nociceptive fibers start to generate, and you get expression of cellular factors such as PGE2 and IL-6, and you get neovascularization, you do get significant pain in some people. And as I said, the secondary phenomenon of facet degeneration, stenosis, lead to the far commoner symptoms of leg pain. You also then get the secondary changes in the spine, so multifidus muscle change, reinnervation, ligamentous change, leading to stiff, painful, creaky backs that mean people struggle with day-to-day life. Again, keeping us all in work, but keeping the society pretty miserable. So in summary, disc degeneration is normal. Compare it in your own mind and in clinic to the graying of hair. So a scan showing disc degeneration is not synonymous with pain, is not synonymous with pathology, it's normal. However, some discs can be incredibly painful and leads to pathology, in particular things like spinal stenosis, radiculopathy, whether that's in the neck, down into the arm, or in the lower back, into the leg, back pain, and at the extreme end of degeneration, it can lead to spinal deformity. So adult spinal deformity is a growing problem in our society, and it's an increasingly difficult problem for us to treat in the aging population. So I hope that gives you some overview of the basic science, and I'm happy to answer any questions. Thank you very much.
That was great, thank you. We've only got one question at the moment, which is the whole intervertebral disc from the notochord, or is it just the nucleus pulpus? So
it's pretty much the whole of the disc, but the end plate and the outer annulus are from the sclerotome. So it is the nucleus fundamentally. And what you'll sometimes see on an MRI is you can see the notochordal remnant, and as you see it as a fine stripe running up the middle of the spine. And that leads to, in some patients, Schmall's nodes, which you may have seen on a scan. If you look up the word Schmall's node, it's like a little flying saucer, a little dint in the end plate, and that's thought to be part of the notochordal remnant. The other thing I didn't mention that you need to remember in terms of the notochordal remnant is the rare pathology that can be caused by notochordal cells living elsewhere. And George, what's the tumour that's caused by a notochordal remnant?
Put me on the spot, I'm not sure. Sorry.
That's a bit harsh. Anybody know the answer? So it's an important rare tumour. Somebody, Makina, chordoma, well done. In there like a shot. Brilliant. So yeah, so chordoma. So it typically occurs in the sacrum, but it can occur anywhere in the spine, and it's notochordal cells that have just been survived but outside of the disc. And that's pretty rare. So it's a benign but highly aggressive tumour. So benign in the sense it doesn't metastasize, but it's a horrible thing to get. Cool. Any other questions? Nothing else coming in there?
Nothing else so far. So if anyone does think of any more questions, Mr. Breakwell will be staying on the course. Just type in the Q&A box and he can type an answer for you. And if not, we'll just move on to our next speaker.
Great. Thank you, George. So I've got the pleasure of introducing Mr. Darren Lui. So Darren's a consultant spinal surgeon working at St George's Hospital in London as an MTC spinal consultant. He obviously has expertise with severe polytrauma, including spinal fractures, as well as spinal cord injuries. He's completed 3 internationally renowned spinal fellowships, both in Dublin, Hong Kong, and more local here in Stanmore in northwest London. His main area of expertise is adolescent and pediatric deformity surgery, but he also has a specialist interest in adult scoliosis, failed back syndrome, and revision spinal surgery. He is an honorary senior lecturer at St George's Medical School and is a reviewer for several peer-reviewed journals. Having worked with Darren at St George's, I can attest to his enthusiasm for teaching. I think very few trainers can say that they schedule pre-trauma meeting FRCS teaching at 7 a.m. So I can guarantee you that you'll have an excellent teaching session from him this evening. And over to you, Darren.
Okay, thank you very much, Ran. Very kind introduction. I will share my screen and minimize my own video. So we're going to talk about spinal fractures and the classification systems and some scoring systems. And essentially this talk should get you to be a day one safe consultant. And I'm going to talk about both traumatic fractures as well as the pathological fractures from cancer, and hopefully just make you aware of some of the names that you will need to know. What's going on here? Okay, so if I was to give one slide and only one slide, and you're in the Viva and someone asked you whether or not you thought you needed to operate on a spine, I think this one slide will get you out of most trouble. And many of you will know, and if you don't, you need to read it and memorize it for your FRCS, but it's the White and Punjabi definition of clinical instability. And if you titrate this down to its 3 most basic forms, it is, does the patient have neurological deficit? Does the patient have instability, which is pain? And could there be an ensuing deformity? And these are the 3 core reasons of why we operate on the spine, but there's a 4th in the middle, which is oncological reasons. And we'll get into that probably at the end of the talk, hopefully if we have time. So why do we use classification systems? Well, it's an injury identification, severity description, allows good communication, guide to prognosis and treatment, and comparisons. And this actually slide is courtesy of Jonathan Lucas, a colleague of ours at Guides and St. Thomas's, and he always said that this was a personal view, it as a knowledge discipline. So I'm going to take you through the AO classification of spinal fractures, and hopefully that will give you a discipline in terms of how to deal with spinal injuries. And you will notice that there are many classification systems, and interestingly, as the classifications are developed, they essentially follow the advance of different imaging techniques. But without going into all of them, the original AO classification was very difficult to use because it had too many subcategories. And the ones that you really need to know, or the ones that are most common, are probably the 2005 Alex Vicar TLIC score and the new Alex Vicar 2013 thoracolumbar spine injury classification system, which takes many of the components of the 2005, but there's a significant upgrade to it. But just to show you what the old 2005 TLIC score was, it looked at morphology, it looked at the integrity of the PLC, and it looked at neurological status, and then it gave a scoring system for whether or not you needed to go to surgery. The biggest drawback of this classification was the use of MRI to look at the integrity of the PLC, and we just don't have MRI scanners in our A&E like they do in the US, and we probably ended up undercalling the problem of the PLC, and having 3 points for the scoring system meant that it was potentially too difficult to use. And there are a lot of papers that came out after this classification system that looked at those fractures which should have been treated conservatively or could have been treated conservatively because that was what the scoring system said. But in fact, the PLC, you just cannot always assess what is going on, and usually due to pain limiting mobilization, a lot of these patients went on to have surgery. So there are more limitations, but to focus on the AO classification or the AO TLICs that now that we use, we divide them into 3 very basic categories: A, B, and C. So A are the compression fractures, B is the tension band, and C is a displacement or dislocation. It really does away with all the subclassifications. And again, it also uses scores to help guide whether or not you should have conservative management or surgical management. And there's a very important middle ground of a score of 4 or 5, which does allow the surgeon to equivocate between whether surgery is necessary or not. And there are modifiers which help to also make these decisions. So for neurology, you can have those who are neurologically intact all the way up to complete spinal cord injury. You may notice that in the past, they gave more weighting to the incomplete spinal cord injury because there was a need to potentially get them to surgery faster. That is no longer a difference in the modern AO-TLIC score. And it's also important that in those who are who have a neurological exam which is not obtainable, you do score a significantly higher point system because that obtunded patient may deserve to have decompressive surgery in order to save their paralysis. Another important change is that by taking weight away from the PLC, it's now known as the M1 modifier. And you simply need to state, particularly in the compression type A fractures, whether or not you think that the PLC could be damaged. And as long as you think it could be damaged, then it scores 1 point. The M2 is an interesting modifier. And I think particularly in those who work in a major trauma center, you may get burst fractures with single end plates, what we call A3 fractures, which on the whole could often be treated conservatively, but in the presence of polytrauma where everything else may need some sort of fixation in order to have early mobilization, you can use an M2 modifier in order to help persuade the kind of swing towards early mobilization by fracture fixation of the spine. So A0 fractures are just transverse process or spinous process, and they don't have any part of the stability. A1 are the wedge fractures, and it involves one end plate. And an A2 fracture is a split or pincer type fracture. The A3 fractures and A4 fractures are the burst fractures. So if you, now when we talk about burst fractures, you either talk about a burst fracture with a single end plate involvement or burst fracture with both end plate involvements. And that is the main difference between A3 and A4. And if you think about the Denny classification, they can be 3 columns as well. You can have undisplaced laminar fractures going out the back, but you may not have injured the tension band, which is what the B-type injuries are about. So when you look at the classic chance fracture, this is a split through the vertebral body and out through the spinous process within bone completely, and in itself is quite a rare injury. Most of the tension band failures are probably going to be B2 injuries, where it's going to involve bony osseous and discoligamentous regions. B3 is a particularly unique type of injury, and it's always worth considering in those with ankylosing spondylitis, and you can see that they are an extension type injury. So going back to the B1 and B2, these are flexion injuries, whereas B3 is an extension injury. And then there's type C, where you can see that there is translation. And this kind of comes back to really good basic orthopedic principles. Make sure you look at the AP and the lateral. Now, these days, of course, you're going to be getting a pan-CT trauma CT, but do make sure you look at the coronal images to look for translation first, and then look at your sagittal plane. So this is the algorithm which the AO use, and it starts by asking you to go from the worst to the least worst. And so this is the discipline. If you look at your scans and you say to yourself, is there translation? Yes or no. If there's not, you move down. Is there hyperextension or a B3 type injury? No, then you move down. Is there a flexion type injury? Could be a B1 or a B2. And then look at the type of vertebral fracture that exists. Is it a burst fracture? And are both end plates involved? And if they're not, then you move down into the A2 and A1, or potentially that there is no injury. So if we have a look at this particular case, he's 38-year-old male, road traffic accident, spinal shock. We're going to look at how we might classify it, score it, say whether it's stable or unstable, and say whether or not we think conservative or surgical management is appropriate. So when you look at this injury, you can certainly see that there is translation. So that is, it gets a C rating, but you can also see that there is a significant tension band injury. So this is also a B2 injury, and it also scores for that. So he's got a C injury and a B2. And if you go back and look at the fracture itself, both end plates are involved. So it's an A4, and he's in spinal shock. So he also has a neurological deficit, which scores 4 points. And potentially a polytrauma, you could say that it's an M2. You don't need to say that he's an M1 because you definitely know that there's a tension band injury in the PLC, therefore is disrupted. So we were always taught to use all of the alphanumerical classification. So it's a type C, it's an B2, and it's an A4, and an N3, and an M2. And so you get a total score of 18, and clearly that's more than 6, and therefore it's unstable and deserves to be considered for surgery as long as all other factors are okay. Here's case 2, 28-year-old tree surgeon, fell out of a tree, has an incomplete injury. We go into the classification. Is it a type C? Well, there isn't really any translation. Is it a hyperextension injury? No, there is a flexion injury. So is it a B2 or a B1? Well, you can see that there is disruption here, and it's probably going to involve bone and disc. So it's B2, and you know that it's a burst fracture. Okay, here's the burst fracture in the canal, and it involves both the end plates. So we work our way through the algorithm. It's not a C, there is a B2 component, and there's an A4 component, and there was neurology. So you add all of those up in the scoring system. The B2, you get 6 points, the A4, 5 points, and 3 is 4 points, etc. And so again, it is something which is unstable and ought to have surgery as a consideration. This is another case of a 59-year-old female. She falls down the stairs. She's neurologically normal. And when you look at the imaging, you can see that the interspinous space is normal in between each one. There's no significant translation. I don't have the coronals for you, but certainly in the sagittal plane, there's no significant translation. So, it's not a C. There's no flexion or hyperextension. And it wasn't a burst fracture, so it's not A3 or A4, and actually it's just an A1, and she has no neurology, so she's neurologically intact, therefore she gets 0 points. This is a stable injury, she can have conservative management. The next patient was on a bicycle turning left, and a bus sucked the bicycle under. Again, it's important to look at your AP and lateral. So here you can see a significant translation of the spine, and again, translation in both coronal and sagittal planes, and goes on to have fixation. But yes, there is translation, and in fact, once you get to that, for that type of fracture, you understand that there's significant neurological injury, and stabilization certainly warranted. So that was just a whistle-stop tour through the AOTLICs, which I think really now supersedes all the other fracture classifications, and should be the one that you use. It's a very good way of making sure you look through all the scans in the appropriate manner and think about not just the morphology, but also the mechanism of injury. And while it doesn't necessarily quantify deformity, and no classification is going to answer all the questions, I think it's so far probably the best that we have. So that's trauma, and I know I don't have a huge amount of time, but I did mention that we also operate on the spine for oncological reasons, and so there are pathological fractures which are due to metastases and cancer. And some just high yield things that you need to know for the exam. You need to know that the SIN score exists. And this is a spinal instability neoplastic score. So it's slightly different than the AOTLICs and trauma, because these are pathological fractures which are being induced by lesions of the spine. And in fact, most spinal surgeons don't often use the SIN score themselves. It's the other people referring to us who are using the SIN score, so the radiologist or the oncologist. But it's important to look for where the injury is in the spine, whether it's painful, whether the lesion is lytic, mixed or blastic, whether or not there is deformity, how much collapse there is, and whether the posterior elements are involved. And it draws on, again, all the things that White and Panjabi spoke about and why we might operate. Now, the other scoring system that I think you need to know, and I know in the Viva, you're not meant to know, or you're not going to be asked to recount the classification, but to be able to tell them why or your reasoning behind doing something, I think is very important. So in the Tokahashi score, and this is the revised Tokahashi score, this is really how spinal surgeons can understand whether or not they should be operating on the spine because of the type of tumor it is. So it's really a way for us to understand better the pathology that is in existence, because that may not be something that we are always familiar with. And the rate that cancer treatment is moving these days, it's impossible to know even which lung cancers will do well. So some genetic types of lung cancer, for example, will have significantly good prognoses. So again, the Tokahashi score is very, very useful for you in the exam to think about whether or not you're going to offer an operation. And it's interesting that, you know, we are looking at whether radical surgery should be offered. So the other name that you need to know is Patchell, and this essentially was a paper, randomized controlled trial paper, that showed that decompression with stabilization, i.e. spinal fixation and radiotherapy, meant that most patients remained ambulatory. And this is really for the palliative treatment of spinal metastatic disease. And this really relates to the core principles of neurology, instability, and deformity. And we know that offering surgery and stabilizing will give the best chance to maintain dignity and mobility and continence in life. But there is something new on the horizon, and whilst it may not necessarily be high yield FRCS, you do need to know that CyberKnife or radiosurgery is in existence and can be offered to patients. And if you look at, for example, this 50-year-old who was skiing when he felt his spine fracture, and he had oligometastatic colonic CA, and he has a pathological fracture of his L4, and it's in the canal. The PET scan shows that he has only one other lesion in his posterior ilium, and therefore, if you look at his SIN score, it says that it's indeterminate, that probably is stable, and therefore there is an indeterminate instability. If you look at the Tokahashi score, it says that actually this person should be considered for radical surgery. Now, I'm not suggesting that you all take up doing Tomita en bloc spondylectomies, and the good thing about CyberKnife treatment now and its existence is that you don't have to do Tomita en bloc spondylectomies. You can use the NOMS algorithm, and this is written up by Mark Bilski, and I think this is going to become high yield in your exam. And this algorithm, unlike other scoring systems, is meant to be timeless, because now it doesn't even talk about the individual type of cancers which are at play. It just, because we don't know in 10 years whether all lung cancers will completely be treatable by chemotherapy. So all it says is, you know, is there neurological low-grade or high-grade MSCC? Is there an oncological treatment which is good? Is there mechanical stability? And is this person able to tolerate surgery? And one other classification system, which is certainly becoming more common, and you're going to see a lot more of them in your spinal oncology MDTs, is the Bilski classification, and the concept of separation surgery. And so in these pathological spinal fractures, we're no longer just treating people palliatively from a patchal point of view. We're trying to offer oncological treatment, which potentially, I use the term loosely, but they talk about radiosurgery having a curative effect or a maximum local effect. And so operating on these fractures, not just because you're trying to maintain ambulation and continence, but because you want to offer significant radiosurgery or cyberknife means that you can offer maximum local control. And so it comes back to this little diagram that I made. There are only 4 reasons that you're going to operate on the spine. It is whether or not the patient may have a neurological deficit, whether or not the patient could have instability and therefore pain, and whether or not this patient has deformity or a deformity that could occur. And you wrap this all together because in the middle is this kind of new frontier that actually spinal surgeons, even for metastatic disease, may be able to offer oncological control. And I think that is it. Sorry if I went over.
No, that's great. Thank you so much, Darren. That's very good. If you know of that, I'm sure you'll fly through your FRCS exam in the spine cases. We've got a question here from Omar asking about the Denis classification. I just trying to
see. Can I answer that, Ran?
Yeah, do you want to answer that, Lee? I think.
Yeah, it's one of my pet peeves. Anybody who's ever been to one of my talks will go on about this. So the Holdsworth classification from the 1940s was from Sheffield. So we bang on and on about the 2-column theory. So Darren alluded to the fact that the classifications get changed every time you get a new imaging modality, and also when you get a new fixation process. And so the middle column of Denis was very important in the era prior to locking plates. So you're all familiar with locking plates on a long bone. So pedicle screws and rods are effectively locking plates. And pre that, you had to really understand the stability of the spine just using wobbly screws. So if you're using a third tubular plate to fix something, you've got to get bone stability. And that was the problem. So the middle column was useful in the 80s. In the advent of pedicle screws and fixation, the middle column is redundant in most surgeons' opinion. So you're right, Omar, the middle column in an osteoporotic is a nonsense. It's an arbitrary thing that Denis invented. There isn't a middle column. There's the anterior column, which is the load-bearing structure of the spine that takes 80% of the load. And then there's the posterior column, which is the tension band. And Darren's effectively talked about that in the mechanisms of injury. So a lot of orthopedic examiners will know the 3-column theory, and it's fine to allude to it, but there are only 2 columns in the spine that have any relevance and any use. And I would stick to that as your argument. So talk about the anterior load-bearing structure and the posterior tension band, and the middle column is a nonsense in modern practice.
Excellent.
I'll get off my soapbox.
No, that's great. That's really useful. Darren, I don't know if you mentioned it, but I just want to clarify for everyone about the TLIX and the AO classifications. To my understanding, TLIX is validated, whereas AO isn't. Is that correct? Or is that my misunderstanding?
I think that's a misunderstanding. AO TLIX has validity now for across the board. There's been a lot of work by AO Spine on that, and
yeah, I was involved in the validation study, yeah. Darren. So you're right, AO is validated.
Yeah, I mean it's just an upgrade of the original TLIX, but I definitely think there are significant flaws with that. In particular, trying to get an MRI for trauma is just not realistic. So yeah, I would move away from that. And for the exam purposes, it's just so easy to, as I said, it's just a discipline in terms of how you think about spinal stability using the AO TLIX.
Brilliant. Thank you so much. Over to you, George.
Our final speaker tonight is Mr. Lennel Lutchman. He's a consultant spinal surgeon at Norfolk and Norwich University. He regularly teaches on FRCS courses and was awarded the gold medal for his exam in 2004. And he's going to talk to you about adolescent idiopathic scoliosis.
Okay, George, can you confirm you can see my slide?
Yep, all good.
Great. Okay, so thank you all. Thanks, Romina, for inviting me to speak. My title includes the Safe Day One Consultant. And if you're going to remember one thing from this talk, it's 3 words, and it's have a system. Have a system to take a history of an AIS patient, have a system to examine them, and have a system to look at the radiographs. I examined for the FRCS Orth, and I can tell you the level of expectation is not high. You just need to have a very basic knowledge of scoliosis, of AIS. Scoliosis comes from the Greek meaning crooked. And one of the things you might be asked is, what's the difference between a structural and a non-structural curve? Well, a structural curve, it has a fixed rotational element to it. And because many people in the normal population have a slight curvature of the spine, the Scoliosis Research Society definition of greater than 10-degree Cobb angle is what defines a true scoliosis. A non-structural scoliosis corrects on side bending. So you have to have a concept that some curves are structural and some curves are postural. The other thing that I find our trainees get confused with is all the different subtypes of scoliosis. And it's important to recognize that what we're talking about is a subtype of idiopathic scoliosis that affects teenagers. We're not talking about early onset scoliosis. Don't go into this exam thinking about growing rods. That's irrelevant to AIS. If you get onto early onset scoliosis, you're doing very well. It's not to do with rib vertebral angle difference of meta that you'll read about. That's to do with early onset scoliosis. We're talking about AIS. So don't get confused. The incidence is fairly high, 2 to 4% of 10 to 16-year-olds is the prevalence. The incidence is 0.2 to 0.6 of the general population. So it's not an uncommon condition. And Mr. Lui, Mr. Breakwell, and I all treat AIS. It's the most common type of scoliosis in this country, with a huge preponderance. 5 to 1 probably underestimates it. There's a significant preponderance in girls compared to boys. With regard to etiology, just remember one thing. If we are asked about it, you're doing well. You should know that there is a genetic component to it, and we don't understand the exact genetic inheritance. It's under investigation and has been for decades. And I think this phrase, which somebody taught me, covers all evils. It's a polygenic inheritance with variable penetrance. Hormonal factors might contribute, and all these other things like neurological abnormalities, collagen fibers, biomechanical factors, and growth imbalance might contribute. But if you said to me in an exam, genetic factors are important, and hormonal factors, including estrogen and growth hormone, might have something to do with it, I certainly think you'll get a 6 for that. You're not going to fail on that. This paper summarizes it well. Scoliosis is a multifactorial condition with genetic predisposition factors is apparently closest to the truth. In other words, you know, you don't need to have an exact idea, just have a broad idea of what the etiology is. With regard to presentation, patients, as you know, if you come to the scoliosis clinic, which I strongly suggest you do before your part 2, patients come because of a cosmetic abnormality. A dance teacher, a parent, a friend notices a rib hump or shoulder asymmetry, and the child presents with a coronal imbalance sometimes, where the head is not centered over the pelvis. Sometimes patients come in with pain, either low back pain or pain over the rib prominence when they're sitting. But pain is not a dominant feature. I might try this one. Okay, sorry about that. So coming on to the next slide, we were asked to mention any relevant papers that we thought might be important. This is a simple table that I just want you to look at. This column shows the curve magnitude at the time of a detection and the age of the child at detection. And the long and short of it is, if you're little or young and you present with a large curve, you have a very high chance of the curve progressing. If you're skeletally mature, and particularly if you present with a small curve, Nackimson in 1982 demonstrated that the risk of progression was very low. This work by Lonstein from 1984 supports this. If your RISA grade is low, i.e. you're skeletally immature, and you have a large magnitude curve, the risk of progression is high. If you are skeletally mature and you have a small curve, the risk of progression is low. The natural history studies by Mackinson also show that when your curve, even the AIS curves, got to over 100 degrees, pulmonary dysfunction could occur, and there was a increased risk of death from cor pulmonale. Fortunately, in our society, that's not something we see because these curves don't get to 100 degrees before patients present. And the last point on natural history that I wanted to mention is the long term. Weinstein in 1981 reported on a large series of patients that he'd followed up, and he found at 40 years follow-up that if your curve at skeletal maturity was more than 50 degrees, the risk of progression was significant. These graphs are interesting. If you get up to a 50 or 60 degree curve, you start getting impairment of the FVC and FEV1. And this was Weinstein's paper, The Natural History of Scoliosis in the Skeletally Mature Patient. So what we're saying is that even if you've finished growing and you're skeletally mature, if your curve got to 50 degrees, it's likely to have some implication on your function in later life. And he also demonstrated that for curves over 50 degrees, the risk of progression, particularly of lumbar and thoracolumbar curves, was significant. So in summary, what we want to do with these kids is pick them up early, identify the ones that are at risk of progression, and like we said in those papers by Mackinson and Weinstein, if you're little or you're young, you're skeletally mature, and you have a large curve, the likelihood is your curve will progress. Equally, we don't want to overtreat children, and what we want to do, judging from Weinstein's paper on the skeletally mature patient, is when they're finished growing, we want to keep the curve at under 50 degrees. So when you have your intermediate case and you're presented with scoliosis, the things in the history, there are two things you want to elicit. Is there anything in this history that implies that this is not AIS? And you have to ask questions that might help you to understand whether or not the curve is going to progress. So have a system. These are just my suggestions. Is there rapid progression? Is there a history of neurology? Does the child have pain, including nocturnal pain? Is there a family history, or is there any history of birth trauma or hypoxia, or any perinatal abnormalities? And did the child have normal developmental milestones? If any of this is abnormal, you're not dealing with AIS, or at least you should suspect that this might not be AIS. Obviously, the age of the child and whether or not the girls had menarche and whether or not there are any sexual characteristics or whether or not they're going through a recent growth spurt will help you assess the risk of progression. So sit down, write out what you're going to ask in your history, and your rationale is any questions that will exclude this being AIS, pain, neurology, etc. A family history, as we've said, genetic inheritance is important, and try to establish what the risk of progression is. Has the girl undergone menarche? What's her age? And what's her growth potential? Those things will help direct how you treat them. So we all have these children in our clinics, two sisters, age 11 and 14. This comes back to, this slide summarizes two things. One, there's a genetic element, probably. And secondly, the variable penetrance. These girls are genetically similar, they're sisters, but the pattern of their curves, as you can see, is entirely different. Our system of history, we need to work out, or you need to come into the exam with a system that covers all the bases. Similarly, when you come to examination, you have to have a system. So presented with the child standing up in front of you on the left, you then have to work through a sequence and work out in your mind how you're going to approach this clinically. The first thing is, when you look at the child from the back, look at the skin, you can see a small cutaneous lesion here. Look for neurofibrometer, look for hairy patches, look for axillary freckling, and make sure there are no abnormal cutaneous stigmata. That's the first observation. The second thing is the head over the pelvis? Look at the plumb line. Apparently in the exam, sometimes they used to have plumb lines. I'm not sure what Mr. Lui and Mr. Breakwell do, but we don't have plumb lines in our clinic typically. We look at the patient from the back, you drop a virtual plumb line from the back of the head, and does it bisect the nasal cleft? Have a system. The next thing to look at is, having looked at the head, look at the shoulders. Are the shoulders level? Work your way down the back. Look at the loin creases. The loin creases in this child are asymmetrical. Work down the back. Have a system. Is the pelvis level? And finally, are the popliteal fossae at the same level? Is there any indication of leg length discrepancy? This picture on the right is the next thing that you should do. You should perform Adams forward bend test, which tells you whether or not the curve is structural or whether or not the curve is postural. And this diagram explains why that happens, why we get a rib hump. And it's because of rotation of the vertebra, and the ribs are pushed posteriorly on the side of the convexity of the curve. Have a system. Just go back to that for 1 minute. So again, my system, or the system that you need to learn, is look at the skin, abnormal cutaneous stigmata, axillary freckling. You've got to think outside the box. Really tall person with broad arm span. Is this Marfan syndrome? Is it syndromic scoliosis, not AIS? You're not likely to get that. You're likely to get a teenage girl with AIS. Start from the top, look at the shoulders, look at the loin creases, look at the pelvis, and look at the popliteal fossae, and make sure you do Adams forward bend test, and you're looking for the rib hump. And you might be asked what causes the rib hump. The next thing I wanted to go through was interpretation of radiographs. Having taken a history for which you're going to have a good system, and done an examination for which you're going to have a good system. I mean, you're obviously going to go through the walk the patient, do a neurological examination, but quite often you'll find that the examiner will stop you. What we want you to do is to be able to recognize that the child has scoliosis. From the history, you would determine that there were no red flags or no alarming symptoms. But if they didn't stop you, you'd go on to get the child to walk, look at the child from the side, look from the front, and do a neurological examination of the upper and lower limbs. Quite frequently, you'll be stopped way before that. If it's AIS, we know the neurological examination is going to be normal. There are no marks to be scored, and the examiners know this. You'll then maybe be shown the radiograph, and again, have a system. The full length, so we've all been here. This is a full length frontal radiograph of the spine. And state the obvious, there's a main thoracic curve, and there's also a lumbar curve. The thoracic curve looks convex to the right, and there's a small lumbar curve convex to the left, which may be compensatory. You don't have to commit, but state the obvious. Then kick in with your system. You draw this line from the middle of the pelvis going vertically. That's called the central sacral vertical line, the CSVL. That's your reference line. That's exactly the same as your plumb line. Is the opposite of your plumb line, basically. You're starting from the bottom, going up to the top. And your comment here would be that looking at the central sacral vertical line, this patient is slightly trunk shifted to the right. Have a system. You start from the top and you work to the bottom, just like we did when we examined the child. The right shoulder is slightly elevated. Have a system. The pelvis is level. Then you look at the upper curve. This is the larger curve, and you might say there's a thoracic curve. It's convex to the right. If they're letting you talk, keep going. It goes from T5 to T12. Those are the end vertebrae. They're maximally tilted. The apex, or the part of the curve that's maximally displaced from the midline, from the central sacral vertical line, is about T9, and the magnitude is about 70 degrees. You can look here, and this is slightly short of a right angle. You're already at a 6. You've already passed on this case. You come on now when we're talking about the lumbar curve, and you might say the lumbar curve is convex to the left. It's from L1 to L4, the apex is L3, and it's about 40 degrees. And looking at it, it might well be compensatory. You're into a 7. Cobb's angle, a lot of people get confused about it. It's pretty simple. You can find it in any book, but measure the angle subtended by the maximally tilted vertebrae, cranially and caudally, which are called the end vertebrae. If you're talking about stable end and neutral vertebrae, you're into 8s. You're well past, and if the examiner is letting you talk, you're well past a 6. You are flying. And if you want to, you can read that up, but this is a technique that spine surgeons use to help us determine the level of instrumentation of the spine. The end vertebra is the one that belongs to the curve. The neutral vertebra is neutrally rotated, and the stable vertebra is most closely bisected by the central sacral vertical line. You don't need to know any of that, but if you want to get, if you want to push it, that's really amazing knowledge. The next thing that you have to know about is bending films. If you get to this point, you're doing extremely well. You're 7s or 8s. Bending films are used to determine whether or not curves are structural or whether or not they're flexible. And this thoracic curve does not go away when you bend, but the lumbar curve does. And therefore, the lumbar curve is compensatory and the thoracic curve is structural. Classifications, don't get bogged down in this. If I asked you, how would you classify scoliosis? Adolescent idiopathic scoliosis. I might expect you to say the Scoliosis Research Society classification, also known as the Lenke classification, is the most commonly used. And I would not expect you to know this. We've got laminated this up in our clinic because I don't know it. But basically, what I would expect you to know is, look, basically, the Lenke classification looks at the structural curves, and there are 3 main areas: the main thoracic, the thoracolumbar, the lumbar. So it looks at the location of the structural curves, the number of structural curves, are they single, double, or triple? And that's all this diagram tells you. The main thoracic, double thoracic. So basically, all I want you to know is the Lenke classification looks at the location of the curve, the structural curves, and the number of structural curves. And just remember, type 1 or main thoracic curves are the most common. You don't need to know anything more than that. If you want to go for gold, then you're looking at 7s or 8s. Read up a bit more about this, but I would not expect anything more from the passing candidate than what we've said so far. We might be expected to talk about skeletal maturity radiographically, and there's lots of indices. Most scoliosis surgeons use the RISA index. It's in your book, read it up, and you should know the RISA classification. It's important to us because RISA 0 and 1 and RISA 2 are skeletally immature people, and the risk of progression is higher. So run through this again. This is a full-length frontal radiograph of the spine. There's a main thoracic curve with a probably compensatory lumbar curve. This patient slightly trunk shifted. The right shoulder slightly elevated. The pelvis is level. There's a thoracic curve, convex to the right, as described before. There's a lumbar curve, as described before. And finally, you might say, you're on a 7 or 8. This is likely a Lenke type 1 curve. You're well past passing this case. This patient's probably RISA 0, and the stable vertebra is L3, and your neutral vertebra is L4. You get 8 marks on that station. Thank you very much. Off you go. This is way, way more than I'd expect the average candidate to know. You do have to have a vague idea about how we treat these people. If the curves are small, we monitor them. If they're intermediate between 20 and 40 degrees, we might brace them. And if they're over 50 degrees, we might offer them surgery. Brace treatment's been studied for many decades, but the one paper that most of us would expect you to know about is the BRACED study, BRAISD, which is bracing in adolescent idiopathic scoliosis. And the long and short of it, this was in the New England Journal of Medicine. And if you looked at the intention to treat analysis of 75% of patients who were braced did not progress up to 50 degrees, 42% of patients who were not braced did not progress. So bracing was far superior to non-bracing in preventing curve progression in AIS. And the other thing that was demonstrated is that the more you wore the brace, the more successful the treatment was in preventing the curve progression to 50 degrees. So the long and short of the brace study, which I think you should know, is bracing significantly decreases the risk of progression to high risk curves in patients with AIS. You should know the brace study and the 2 conclusions. It's better than not bracing, and it's dose dependent. And the last thing I want to talk about is surgery. You should be aware that this is a distraction rod called a Harrington rod. It was the original scoliosis surgery, but all you need to know about surgical treatment is modern surgery uses segmental fixation with hooks and anchors, hooks or screw anchors, and cobalt, chrome, or titanium rods. And the Lenke classification and the use of the stable and neutral vertebra, all of that is to help us select the fusion levels. You don't want to fuse the whole spine. You want to keep mobile segments in the lumbar spine. And the longer the fusion, the higher the rate, we think, of long-term degenerative changes in the rest of the spine. This is a double major curve that requires more extensive surgery. And again, to conclude, this girl, this kind of shows you why we classify, why we use Lenke. If you, this stable vertebra is probably L3. This patient was fused short to T12. And what you get is a phenomenon called adding on. So the importance of the Lenke classification and classifying these curves is to properly select the levels that need instrumentation. And this patient needed to have further surgery. So that's the reason we classify them. I wanted to finish with this slide. You'll all be aware of tibia vera. You'll all be aware of hemiepiphysiodesis using these plates to achieve a correction. So if you're asked about new technologies in adolescent idiopathic scoliosis, you've already scored your 8. We don't have a 9 on the marking sheet, but you might be expected to know that vertebral body tethering is a resurgent technology. It's been around for a while, and it's out again in its latest incarnation. But the idea is to perform a convex hemiepiphysiodesis using screws and a tensioned band. And basically what this is hemiepiphysiodesis. And the principle it's working on is the Hutter-Volkmann principle, which is if you compress a growth plate, it'll slow down. If you distract it, it'll grow quicker. So this is using the Hutter-Volkmann principle to halt progression of idiopathic scoliosis. You just need to know it exists. It's not yet in widespread use, and it's still being investigated. So in conclusion, I hope you have an idea of how to define scoliosis. Is it structural? Is it postural? Over 10-degree Cobb angle. We're talking about adolescent idiopathic scoliosis, not syndromic, not early onset. Get that clear in your head. Have a vague idea about the incidence and the etiology, and the natural history depends on the age of the patient and the magnitude of the curve. If they're skeletally immature and they have a large curve, the risk of progression is high. Have a system for looking at them clinically. Look at them from the back, look at the skin, start from top to bottom, look at them from the side, look at them from the front, look at them walk, and do a neurological examination. You won't get very far past looking at the back. Most of the time you'll make the diagnosis and the examiner will stop you because there is little to be had in examining the patient neurologically, because they should be normal. If they're not normal, by definition, it's not AIS. You should be able to basically interpret the radiographs. And if you've done it in my systematic way, you'll hit everything and you'll be way over a pass. Lenke classification, how do we do it? It's based on the location of the curve, thoracic, thoracolumbar, or lumbar, and it depends on the number of curves. That's all you need to know. Learn about the brace study, read the paper and the rationale for bracing, and the principles of surgical correction, like I said, are segmental fixation, and there are currently being investigated some movement sparing procedures. So I'm happy to entertain any questions, and I'm very fortunate to be joined by Mr. Lui and Mr. Breakwell, who are very experienced scoliosis surgeons. So I'm sure they'll have a view on what their system is to examine. I don't think there's a right system, just have one.
Thank you very much. That was a fantastic overview of AIS in 50 minutes, and certainly going to be some exam gold on YouTube there for my revision.
That's great. I think there was a question that Lee's already fielded, which is in relation to the brace study. So I don't think there's any other questions, but that was a phenomenal talk. Thank you, Lennel.
Lee, Darren, if I could just pick their brains. What's your system, Lee? And what's your system, Darren? Faced with a back, you're looking at a girl in clinic. Is that pretty much what you would do? Or have you got any variations or any additions or refinements?
So, no, I agree with everything you said. I think the key is to be logical and to be systematic, particularly in the exam, but also in real life. I don't use a plumb line either. You eyeball it. You get the lines on X-rays these days. We use surface topography scanning, as you know. which is just another way of measuring the three-dimensional deformity. EOS X-ray is an interesting concept that we are lucky to have that gives us ultra low dose. But from a clinical perspective, you nailed it, really. That was everything I would want to say.
Darren?
Yeah, no, I agree. It's a great system. You start from the top and you work away to the bottom, and it's the little things that the guys are going to be picking up their points on, like this stigmata, rapism. The only thing I would add is that on the Adams forward bend test, I also make sure I side bend them to look at the flexibility of the curve, so that you get an idea of how much the rib hump might go down. And the other thing that the guys should be aware of, you're looking to see if there's a loin hump, because that is a clinical reason to extend your fusion into the lower spine. But it's not for everyone. And I guess points can be scored by saying, often a boy might choose a selective thoracic, even though he has a double major, whereas girls, it of course is much more of a cosmetic concern. I think you absolutely are right. They've got the trainee must be able to understand that the presenting complaint is often not pain and it is cosmetic. And you look at Halali Noordin's classification of AIS, and it's based on shoulder height and pelvic tilt and truncal shift, not X-ray parameters, because that's what we're going to end up correcting, isn't it? So it's and as you said, the bending films are really important to help us with that.
So Lennel, do you want to comment? There's a question from McKenna about the rib hump. You alluded to it, and sorry, George, I'm doing your job.
You read it out for me, George.
I was just asking if you could just pop the slide back up with the rib hump on at all. Just
sure. So let's share screen again. Back up here. And then if we
this is really an important concept to get your head around as to what you're seeing on an X-ray and sort of making that fit the patient.
Yeah. So I think what the hell's this thing doing? Oh, bloody hell. Okay, so it was this one down here. Yeah. So what it shows here is this is the fundamental difference between a postural scoliosis and adolescent idiopathic scoliosis, and its vertebral rotation, and the convexity. The spine rotates. It's rotating in this direction, so the rib is pushed posteriorly on this side. This is the side of the convexity. It's convex on the right, it's concave on the left in a classical curve. If it's the other way around, that's called an atypical thoracic curve, and that's associated with being non-idiopathic. This is important as well, not just clinically, but operatively. When you come to put screws on this side of the spine, the convex side, they're fairly vertical. If you have a very severe scoliosis, the screws on the concave side are very, very horizontal. So usually you get your consultant colleague who's double scrubbed with you to do the worst side, and you do the easy screws. They make you look really good. So look at that photograph. That's what you see when the patient's bending forward. This is the convex side. And on the convex side, the rib cage is pushed posteriorly. And I hope that answers the question. George, is there anything further?
So there's one last question we'll take. So it says, Mr. Lui mentioned how most patients present for reasons for cosmesis. My understanding is that we do offer surgery for COB over 50 generally. Does this create difficult conversations in clinic in refusal of surgery for cosmesis reasons?
Yeah, so that's an interesting question, and I'm sure my co-faculty members would agree. We spend an awful lot of time in our clinic trying to talk people out of having surgery. One phenomenon that's very common is the girls have reasonably well-balanced spines. They don't look bad at all. They have an X-ray, and the X-ray causes a jaw drop. They come in the clinic really happy. You flash the X-ray up, and I build up to it. There's a lot of psychology to it, because they're going to be alarmed. The X-ray always looks worse than the kit. And then you have to talk them around it. Sometimes you've got to go on Google and show them a severe curve and say, look, I know that looks horrible to you, but that does not, we would not recommend surgical treatment. So in answer to that question, yes, we spend a lot of time, as much time consenting people for surgery as we do talking people out of having surgery. I'm sure Darren and Lee have the same experience.
Absolutely. And it is really tough with if you've got a lanky one, so one of the examples of the right thoracic where you get quite a lot of trunk shift, it's really hard saying to a girl of 43 degrees, I'm sorry, you can't have.
Yeah. One of the things about bracing, apart from brace, is Lee and his colleague Ashley Cole are doing a study of nighttime bracing. So again, that's plus marks. The brace study is fundamental. And it certainly was not revolutionary, but it reinforced our suspicion that it was worth doing. Indications for a brace, you have to have a flexible curve. You have to have a skeletally immature patient with the right body habitus who's going to be compliant. If the kid's not going to wear it, there's no point using it. And they need to be wearing it for 12, ideally 18 hours a day for it to make a difference. It is dose dependent.
Great, thank you so much. And thank you everyone for your time this evening. We've run slightly over, but some excellent teaching. I think it was worth staying a little bit longer. Can I just remind all our participants to please do your feedback when you get it at the end of this session, and we'll see you next month for pelvis.
Thanks a lot.
Cheers. Thanks a lot. Bye-bye.
And then George. Good night, Lennel.
Cheers. Bye-bye.